Today I'm sitting down with Dr. Emily Mendenhall, a medical anthropologist, Guggenheim Fellow, and professor at Georgetown University who has spent 2 decades studying how trauma, culture, and chronic illness intersect. She's the author of 6 books, and her latest, Invisible Illness, A History from Hysteria to Long COVID, is one that I think you all are really going to connect with. We get into the long history of medical gaslighting, why patients are still being dismissed today, the concept of structural silencing, and why understanding chronic illness means looking at far more than just biology. This is one of those conversations that will probably have you nodding along and maybe, hopefully, feeling a little less alone. So let's get into it. The Chronic Illness Therapist podcast is meant to be a place where people with chronic illnesses can come to feel heard, seen, and safe while listening to mental health therapists and other medical professionals talk about the realities of treating difficult conditions. This might be a new concept for you, one in which you never have to worry about someone inferring that it's all in your head. We dive deep into the human side of treating complex medical conditions and help you find professionals that leave you feeling hopeful for the future. I hope you love what you learn here, and please consider leaving a review or sharing this podcast with someone you love. This podcast is meant for educational purposes only. For specific questions related to your unique circumstances, please contact a licensed medical professional in your state of residence. Emily, I'm so excited to have you here. Talking about medical gaslighting is really why this podcast came to be. So I'm really looking forward to hearing about your new book and also just what drew you to this work. I'm sure you've been asked that a million times, but I would love to also let our listeners know who you are personally and professionally.
Yeah, thank you. It's such a delight to be here, and I'm looking forward to connecting and sharing this work with your community. I'm a medical anthropologist, so I study how health, culture, and society interact. And for about 2 decades, I've been studying how trauma and chronic illness become embodied. So I'd studied public health and worked in Zambia and Guatemala, and I was really interested in working in the US. So I got a job at Cook County Hospital in 2006 and started working with Mexican immigrant women seeking care for diabetes. And I ended up working there for 4 years while I was also doing my PhD in anthropology. And as I started working on kind of issues of health and immigration and asking women about their diabetes, really what they wanted to talk about was kind of social trauma and distress and financial insecurity, like all the squishy stuff that didn't have to do with the biology, but was like deeply embedded in their biological experience. So I became really interested in this work and in spending time with this community. So I ended up working at the hospital for about 5 years while I was doing my PhD. And then I was recruited to do an NIH postdoc, and I worked for a year in Delhi with the Public Health Foundation of India, looking at similar patterns of how chronic illness was experienced across income groups. And this was one of the first ethnographies of what it was like living with diabetes and in poverty in India. Which was a really fascinating experience. But I also felt I was just very curious about how much was culture and how much was power. And, for also personal reasons, we moved to South Africa, and I did another postdoc looking at the experience of living with diabetes in a context with really high HIV in Soweto, a neighborhood in Johannesburg. So I had been doing this work, and then I did another comparative piece in Kenya, and then I did a little work in the Somali region of Ethiopia, looking at what it looks like to live with chronic illness across cultures. And I think it's really powerful to understand how deeply cultural and social living with chronic illness is, and how we even think about illness is culturally constructed. And I work on this concept called syndemics, how social and health conditions travel together and what that means. And that's something I worked on for a long time. So that is a lot of my earlier work, and it's all really the culmination is written in a series of papers I edited in The Lancet, and also a book called Rethinking Diabetes. But as I was wrapping up some of that work in South Africa, and after I'd done the comparative work in Kenya too, I worked in South Africa as honorary faculty at University of the Witwatersrand for about 12 years, so I was still kind of doing work there. COVID hit, and I had 2 small children. I was living in DC, and everything was online. So we packed up our kids in the car and drove west and out to rural Iowa, where my family lives. My brother-in-law was leading the COVID pandemic response in that local community, and we arrived in the middle of an outbreak. And I was like, what is happening? Because in Maryland, we had police outside of the grocery store not letting us go in without a mask. But there, no one was masking. And they were acting like there was no pandemic, so it was very weird. And so for me, as someone who's, good friends were working in global health security and like, advising the Biden, or at that time, not advising Trump, but they were advising the State Department,
Yeah.
and then eventually worked with Biden on the COVID response. So these very high level people. So anyways, I rolled up my sleeves and started helping and doing interviews and trying to figure out what was happening. And I got really passionate about it, and I ended up writing a book called Unmasked. And this unmasked COVID community in the case of Okoboji really drew me into just thinking about COVID in a very deep and cultural way. And then after I was writing the book, a student of mine got really sick with long COVID. And during that time, he was going to withdraw from school. But I said, you know what, maybe you need to, but why don't you start writing down a really deep kind of like narrative therapy,
Yeah.
or therapeutic journaling sort of. But why don't you just do an autoethnography, write down all your feelings, all your experiences when you go to the doctor, what that's like. I mean, it's full of medical gaslighting. Like that is just like such a deep part of this experience of his journaling. And then when he started feeling a little better, he started doing all these interviews, and we just got really interested. And then I ended up applying for I was myself very exhausted, and I actually got COVID about a year later, and then took me about 6 months to recover, 4 months really, and 6 months to be kind of at a more normal active level. My anxiety went out of control. I became really fatigued. And like I argue in the book, whatever underlying condition you have, for me, I have an anxiety disorder. So it's not surprising. Some people do not have any mental health conditions linked to their condition, right? It's more physical. It's a heart condition. It's a respiratory condition, something else. But for me, it was anxiety. And so I became really interested. So I submitted for to the Guggenheim Fellowship, and I ended up getting it, which was just amazing because I had this time to really think. And I did over 150 formal interviews and talked to hundreds of people, as anthropologists do. We dig in and peel across the layers. And I was going to write a book on long COVID, but I started doing these interviews, and I was like, it's not just this isn't a story of long COVID. Long COVID is one part of the story. I talk about chronic Lyme, I talk about endometriosis, I talk about, all sorts of conditions, ME/CFS, these long-standing conditions. And I always also put the patient advocacy group stories within this long history and tradition of gaslighting and what it means and how patients have organized and collectively worked together.
Yeah.
And yeah, it was
love, yeah, there was a like weird kind of experience when long COVID first started being talked about. Those of us who had contracted Lyme disease were like, they're finally going to believe in chronic Lyme. And then honestly, like 2 months later, I started to hear little murmurs of like, no, long COVID isn't a thing. Chronic Lyme still isn't a thing. Like, and I remember just feeling so heartbroken. I will say 5, 6 years later, I'm like, okay, we do have long COVID clinics. People do believe long COVID exists. Gaslighting still, of course, exists, but I've seen so much more hope in medical doctor responses recently than ever before. I'm curious, what you're seeing.
Yeah. Yes. And I wrote the book basically as an advocacy book to tell a story, and it's an intellectual book. It's a history, it's a deep history. But I felt by putting this kind of history of dismissing women and not believing pain, which obviously is amplified tenfold for Black women in America. There's so much anti-Blackness and racism in medicine. But for all women have different kind of social identities that ebb into that interaction in the clinical space. And, I wrote the book as a historical piece because it's not just about your diagnosis. And, many people have multiple diagnoses. They have a primary diagnosis, but they have many conditions. It's really about that social experience in the clinic and what that means. And without recognizing, the social and in some cases, the psychological aspects, you can't even understand the biology. You can't even get to the heart of the matter. And, I deeply believe that, health and is a deeply social and psychological and biological. So it's really important to have a deep understanding of people's real experience. And one of the critical arguments of the book is that patients need to be respected and treated as knowledge partners. And without that, especially when you have like a weird condition, that no one, that maybe
Exactly.
your clinician has never studied, or doesn't understand. And that's one of the challenges is so many people, people with endometriosis, for example, have from like 5 to 8 years, an odyssey to have a diagnosis. And that
Absolutely.
is just so painful, so painful. So
That's right.
understanding these stories, I think it seemed like such a bigger story than just long COVID, even though long COVID is so much.
Exactly. Yeah, I absolutely. Yes, that is it. And I think a lot of us have been talking about that, and especially again, those of us who were diagnosed with something before COVID, whether that was ME/CFS or um, Lyme disease and things like that. It really was a what's the word I'm looking for? It was like relieving, or it was just, yeah, to have the evidence right there. Like it can't be, like I said, I did start to hear people starting to, like, murmurs of starting to deny long COVID, that was a thing. And then that didn't last too long, thankfully. And I'm so glad there are books to go along with this. I mean, my community always asks for books, and I hope you know how important your work is.
Thank you. Yeah, it felt you know how it is. I'm not a therapist, but I spend a lot of time with deep listening. It's actually
Yeah.
what I love most about my job. I used to joke that, I need to put hugging into my protocol, my research protocol, because
Yeah.
it's such a deeply shared emotional experience to spend hours with someone listening about their life story. If it's 1 hour, maybe, but often it's much longer and so much follow up and multiple conversations. And I think it's really deeply an honor to do that work.
Yeah.
Um, and it's
Can you
meaningful.
talk a little bit about that history? I know your latest book, Invisible Illness, A History from Hysteria to Long COVID. Can you talk a little bit about that history of hysteria you can give us today? But yeah, what are some of the
Yeah.
experiences that still even happen today that used to be called hysteria that now is
Mhm.
something still happening, but is
Yeah.
looks different in our modern day?
Yeah. Hysteria has long been a construct used to explain away women's suffering. Saying, it's a problem of the womb, it's part of the ovaries, it's this or that is different, right? That makes us distinguish. And it's just like kind of like fat phobia today, and still is somewhat used, weaponized in this way where it's like, no, it's your
Mm.
weight, or it's just you're a woman, it's fine, it's just menopause. And the longer history, it was, I think, much more harmful in centuries past. I mean, even the Egyptian scrolls talk about women's illness as of the womb, and kind of essentialize that. And we still don't really study it. We still don't have a deep neuroimmunological study of women's bodies and women's experiences and how viruses hide in the nerves and in the tissues, in the gut, and how that plays out in our bodies. We still have not. There are some incredible people like Mike Van Elzekler and Amy Prohl at Polybio and others at different institutions who are doing this really great research. But there's just still a huge vacuum of our understanding, because women post reproductive age are often ignored. So historically, if we think about hysteria, I start primarily with Charcot, like talking about how hysteria was framed, and what it was used to do. And even in that, before Freud, it was used much more as even linking to neurology, linking to the physical body in a deeper way. And it was really Freud who changed the ways in which we talked about it as largely trauma based, which was a huge undermining of women's realities, biological
Yeah.
realities. And in some ways, some feminist studies have steered away from biology. And there's this like amazing work by Emily Wilson, a science historian, who I draw on because she talks a lot about the biological realities of so much of this misogyny, and how we think about health and illness, and how taking biology seriously is so crucial. Um,
I've seen that too. This the idea that, men and women are different has been used historically so much to oppress us that it's easy to go into a place of there is no difference, and therefore, but that does really reduce their ability to see our bodies as something unique. Is that kind of the point that you're making?
yeah, exactly. And I think actually, instead of talking about our difference from men, what about our qualities that may and that we can, possibly seek to find to help us live better, right? And that's, I feel like that hasn't been something really prioritized. And by marginalizing our own realities, it's been really a problem. So I think a good example of something that was long coined or called hysteria is MS. So once MS was identified as plaques in the brain, even though there wasn't a clear treatment, the whole experience and categorization of someone with MS was radically changed and validified. So conditions that don't have like plaques in the brain that are, in a quick clinical interview, unverified, this means these unverified conditions can be verified by biological anomalies through super expensive tests that you can find that, I found, I've interviewed people who spent just thousands and thousands of dollars on verifying that they're sick with what they think they are sick with. And because insurance
Yeah.
doesn't cover it, it just bankrupts people.
Yep.
It's, and because there isn't an in-clinic test, people have the need to verify the biology. And, some long COVID and ME patients really have been frustrated with my book because I don't say it is clearly this biological problem that has a quick biological fix, because that's what people want. We saw that with HIV. We saw antiretrovirals were really effective, and there may be a biological fix, right? That they can tackle and dissolve or suppress the virus. But we don't have that yet.
Yeah.
And we don't know if that's even a possibility, but because we don't even test where the virus sits, it's really hard to do that work.
Yeah.
But just like HIV also, for example, is a deeply social and biological experience. It is, I've done work with people who actually say HIV is so much better than diabetes for me because I can take HIV medication. I did this work in South Africa and in Kenya, people who are living with HIV and diabetes. And they're like, because I can access medication, but I can't for HIV, but I can't pay for medication for my diabetes. I have to like modify my food and affect my whole family. I'd rather just care for my HIV. It's such an easier disease. So like I know that medicine can absolutely transform, but it's always so much more than that because no one lives with one condition. So really thinking about these conditions as holistic is absolutely crucial.
Yeah, I know there was like this thing going around online maybe last year. I feel like it was a lot that like fibromyalgia might be autoimmune. And I remember like commenting with somebody and I was like, well, it's not an autoimmune condition. And they were like, they got really, really upset. They're like, how dare you? That's so dismissive. And I realized I knew what was happening in that moment. It was like, you so desperately like really need the biological answer because otherwise it's
Yeah.
dismissed. And I get
Yes.
that. That's fair.
Yeah, and it's
Yeah.
so fair. And these people who have been really upset kind of with invisible illness because I don't take an explicitly biological stance, I think I mean I just feel really deeply for them, to be honest, and I have been trying to be very respectful and appreciative of their engaging with the work, even when they're not very nice to me,
Oh,
because honestly, they're suffering, right? And they
yeah.
want that biological fix to be the answer and the one path forward. And
Yeah.
the fact that we've done so little research comparatively to get there is extraordinary. And I was interviewing Tony Fauci is on
Yeah.
faculty at Georgetown, and I've interviewed him several times, and I interact with him pretty often. I actually read his whole 500 and whatever page book because I had to interview him about his book. It's actually, you should listen to it if you're interested. It's like 19 hours of his like lovely accent telling you about his
Okay.
life. But what was so fascinating in my interview with him and then actually listening to his book, which actually he wrote, I thought he had a ghostwriter, but he wrote it himself because since HIV epidemic started, he started taking like field notes like an anthropologist would every night, writing notes about his conversations and his experiences. It is out of this world. It is like a historical document of the nation, in my view. And I know some people don't like him because of this or that, but it is true that he was looking at autoimmune diseases and immunology, and he stepped away when HIV took over. And, I talk about in the book how HIV flooded health and public health, and it took away from, it stifled research and innovation away from the ME community at that time, in part because there was so much money and influence and, in that area. And there was also some visibility of what to measure and what to study. And, it was just sucked all the money out of the room. And he said, I was actually looking at some of these conditions, post-viral conditions, and autoimmune conditions before HIV. And then I just did HIV for the next 20 years, 25 years, and that is true around the world. And I think it has played a huge role and I do think it was gender, and I think it was power, and I think it was the manifestation of the illness. But it's something that we need to talk about. And it's something that I try to talk about in the book because, we really need more money and time and just attentive research
Yeah,
to understand
I've
these
noticed there's a
conditions.
lot of research coming out of the UK right now on ME/CFS, like a lot, and the Make Visible podcast is really reporting on that really well. Um, I'm curious, like when people get upset about your framing in the book, what is the framing exactly? Is it that you're talking, do you kind of state like, well, we don't know what the biological nature is behind this, or what is the like actual
Yeah,
upsetting?
the framing. Yeah. So
Yeah.
the argument is if you don't, I mean, this, if you don't focus explicitly on the biology, then you're harming the community. And I
Okay.
completely understand that. But the framing, because of the urgency to have a biological solution, and you don't want to distract from that. But the reality of it is that long COVID is not one thing.
Yeah.
And
Yeah.
that's the challenge of diagnosing. ME/CFS is not one thing.
Yeah.
And honestly, a lot of patients organize their whole way of understanding these conditions as septad, which is basically the interaction of 7 categories of illness. And, the fact of the matter is that people have a primary diagnosis, but they often, like you were just saying, you may have fibromyalgia, but you might also have Sjogren's disease, and you might have Ehlers-Danlos syndrome, or you might have these other conditions. MCAS is like so common among the most people I interviewed. So it's not a very clear, this is the problem and this is the solution. And that's what people don't like. So I present this.
Right.
Are you familiar with like allostatic load and weathering and
Yeah.
exosomes? Yeah.
Yeah.
Exosomes. So I draw on all of those theories of cumulative trauma, which is not
Yeah.
trauma. It's viruses, it's bacteria, it's invaders. It could be trauma, but that's
Yeah.
one
When
of
people hear trauma, they think for some reason still, right, that it's your fault. Because it's even like, let's
it's
just say it was
emotional.
just like
Exactly.
trauma that happened to you. Like, okay, that's still not your fault. But yeah,
But
as you're saying,
trauma is not, yeah,
it's not just emotional. Yeah. It's all of these
it's
other
not just
environmental.
biology. I mean, yeah, I mean, it's all of these things that come into the body and become expressed. So my theory is, which is a theory because we don't have the biological evidence, and I don't think we're probably ever going to, because my argument is that medicine is really limiting because we are not, we live in our biology, our bodies are systems. We're not machines.
Yeah.
And that's why medicine fails to care for people with complex chronic conditions, is because our bodies are systems, and when we care for them as machines and we try to tweak one thing to fix everything else, it doesn't work because one thing affects
Exactly.
one system, and we have microbiomes that differ all over our bodies. So the virus functions in one way in one area differently than another, and we know that.
Yeah.
And and there's so many different experiences that people have, and that's why we know that long COVID may affect the heart, because you have an underlying heart condition. It triggers
Right.
that vulnerability. And the fact that I have this thresholds metaphor, which is, I mean, I could have just used allostatic load, right? Or I
Yeah.
could have used weathering, but thresholds felt like something that could bring those theories together in a way that spoke to the community, where it really is the tipping point. So why do people with the same genetics possibly, one person gets sick with long COVID and someone else doesn't? Well, there's probably other things that have transformed. It may not just be epigenetics, that, it could be epigenetics even, that like an environmental exposure during your childhood turned on a gene or turned off a gene. Like that is a
Yeah.
real thing we have proven is real. It
Yep.
may
Exactly.
be, and that could have been trauma, but it also could have been exposure to smoking or, a chemical or anything in our bodies that that physically transform your vulnerability, your
Yeah.
biology. And we
Yep.
just don't have the data to explain what that is. But
Yep.
I think, I mean, the hundreds of people I've spoken to, this theory of thresholds really resonates. That,
Yeah.
and a lot of people who've gotten really sick, especially those who've had cancers, have a deeply weakened immune system.
Right.
And it's just the reality of what we're seeing, and it's important to
Yeah.
understand the complexity matters.
Do you notice a generational difference in how people respond to your work?
Um,
Like,
well, I think overall, let me just say, I've had a great response to the book.
good, good, good.
It is a very small online ME community that
Okay.
I feel has been deeply scarred, deeply scarred and treated very badly by the
Yeah,
medical
yeah,
community. And I
yeah,
feel for them so much. And I do think we need more research. I mean, the book is a call for taking these patients seriously and putting their knowledge at the center of their treatment.
yeah.
Um,
I think you're right. People are
and
just so desperate for an answer, and so they
yeah,
probably go into that subset, go into your book hoping for this answer, and you're not. That was never the
I
point
mess it up.
anyway.
I mess it up
Yeah,
even more because I'm like, it's not, there's no clear cut. But I also know that like two people read it and they don't like it, and then they tell everyone else all this stuff. And some of the reviews that have been written by this community, just like two, but they've
yeah,
just been very vocal, have just been like totally misinterpreting the
yeah.
entire book. But it also is just a reminder of how desperate people are for a solution and how urgent this
Exactly,
research really is.
exactly.
But also, and people get really angry when you say that when you say that treatments need to be multifaceted and how crucial counseling is. But like honestly, psychological problems are not probably driving long COVID. But when you have chronic illness, the one thing I've learned is that it's really hard, and
Exactly.
when you're living with chronic illness, if you're not getting help, you're suffering more.
Yep.
And, that's just a reality of living with a really tough illness that completely changes, especially your social identity.
Exactly.
So I think it's important to recognize that.
Yeah, that's the whole point of this podcast. And as I started this podcast 4 years ago, I was also just in this very kind of, how do I frame this? Because so many people are being handed a referral slip saying you need to go see a therapist, which has often meant this is in your head and you need to go work on that. But also now, what does that mean when they're handing you a referral pad for a therapist? Because this is really hard and you deserve the help and support that a therapist can offer while you're going through this journey. And so I wanted this podcast to be a place where people could be like, wait, no, therapy could work for me because it's not about curing my condition. It's about getting the support that I need throughout this condition.
Yeah. And I think that's actually really crucial is so many people have recovered are not at baseline. They're not at the
Yeah.
baseline they were at. They're at a different baseline and they're living slightly differently. Like I certainly am. Like I got the flu in November. It took me 2 months to recover.
Yeah. Yeah.
And my family was better in 2 weeks. But
I
that's just
know.
my reality now. And you know what? It sucks. But it's also okay for me. I mean, I have such a minor effect, but I don't know.
It
It's
is. And
when
that adjustment therapy that's what we're here for, is to help through the
yeah,
adjustment to a very difficult situation. It doesn't fix your
yeah,
situation. It doesn't cure you from anything. But it's a trauma like any other, losing your
yeah,
house to a flood,
yeah.
anything.
Yeah. Yeah, I was just emailing with this woman, Bethany, who I interview at the beginning. I introduce at the beginning of the book, and she's probably the person I had the most intensive discussion with. And, at the beginning, I reached out to her and she was thinking, I mean, she, like many people I interviewed, she had suicidal ideation, and I was so worried about her. And so I would check in with her every few weeks and we would talk, and I would just kind of check in with her. And I just emailed her, see how she's doing. And she's like, well, I can't really stand for very long, but she's still making art. And like, she's really suffering. And I think that when people are not seeing that recovery and are just kind of, she can't leave her house, like finally, I think the lack of state support of our safety net are like incredibly weak, and really unjust safety net in America is making people so much sicker and so unwell that just being able to justify yourself that you should be able to keep your house because you can't work anymore is incredibly demoralizing. And this is something that came through so strongly in my research.
Yeah. Yeah. Can you speak a little bit more to that concept? I mean, that's the political atmosphere being talked about here is not, it's not a stranger to the show, but yeah, I think it goes, and it's not just this administration too. I mean, it's every administration. We don't value disability, disabled people.
our country is really about profit, and our whole culture, and I do actually talk about the culture of individualism in the United States, and I talk about this in my book Unmasked too. This is how the culture of individualism and COVID denialism really, dismissed the vulnerable. They're like, let them die, or, I'll protect my grandma, but everyone else, whatever, I just won't go see my grandma. Like, I want to live my life. And that sort of dismissiveness, even though I argue that, like, and this is, everyone will probably relate to this, is when we were all quarantined in our homes, at least the first 2 months, then some people didn't quarantine anymore. But during that time, it was the first time people really felt stranded because of a biological vulnerability. And maybe one of the only times in their life they have or will recognize what it is like to live with an invisible illness that doesn't enable you to spend much time outside of your house. And that loss of social identity is so powerful and so important to understand. And so the fact, I mean, so many people who I interviewed just had, submitted a disability 1 to 3 times, and then they finally got enough money, or someone loaned them money to, I mean, it's really a class thing in America. Everything is about class. Not only about class, but our the ways in which we have hierarchies, which are only getting worse as the wealthy get wealthier and the poor get poorer, especially right now, with, effects to SNAP, the Republicans consistently trying to squelch Medicaid by, by doing block grants, by reducing which states get what. And this, of course, affects people living in red states more because they accept those limitations more. It just makes it really difficult. So if you can't work, you lose your job and you lose your house and you don't have I mean, the one thing that I've learned around the world working in resource constrained settings in general is one of the most important things you can ask is, do you have someone in a time of crisis to lend you money?
Yeah.
And I don't know if you guys have read this book, Crowded Out, but I think your listeners would be so fascinated by it. My good friend, Nora Kenworthy, who's a medical anthropologist and does a lot of political anthropology, did this whole study. It's called Crowded Out is the book. But it's about GoFundMe. And what's inherently, so GoFundMe is just like typically used now for all sorts of medical conditions because our health system is complete failure for people. And I was just like watching the Facebook messages of a friend I grew up with in rural Iowa who now has a chronic severe condition, and she's been a nurse. She's like an NP, and she can't afford this care. She can't afford the care. She's worked in the health system her whole life, and she has to have a GoFundMe site to pay for her medical bills, and she works in a hospital. That is injustice. But Crowded Out shows that not only is it that our insurance systems and our state systems are unjust and too limited, but also these cultivated network-based systems are unjust because, you're most likely to be friends with people who are like you. Yeah. And because of that, if you have more money, it's easier for you to get social credibility and to raise a ton of $1 million. Like, what is it, that actor who just died of cancer? They earn $20 million or whatever it is, or $2 million. I don't know. It's all the same.
It's
at
really
some point,
sad.
But like, yeah, it just so much money because of his social networks. And that's an extreme case because he's a famous actor. But it plays out in our medical system is that poorer you are, the less likely it is to even raise that kind of capital. And it's just incredibly unjust. And I think long COVID and ME and, all of these chronic Lyme are these conditions that insurance companies are actively trying to deny because of the prolonged care people need. But they're suffering the most because they're, some people I've interviewed have said their families don't believe them. So this woman I spoke to was living in the rural South. She lost her house. She had to move 3 towns away. She's living with her dad who doesn't believe she's sick. And she has a lot of cognitive loss. So like she can't work. So her dad makes her feel bad every single day. She's in her mid-40s. And he's like, you're so useless. You're not working. You can't do anything. And her lawyer told her, be better if you're homeless. It'd be more likely you could get disability. I mean, these are deep injustices that are just I think these illnesses don't just demonstrate the misogyny, but they demonstrate the way in which our system, our political system, and especially our health system are so broken. So
Yeah.
these are pieces, these are elements that really come out through the book. And, one of the most powerful, I think, arguments of invisible illness is this idea of structural silencing. And what structural silencing is, which I argue, is it's not just like the inequities of laws and institutions, which make it hard. Structural violence, a term we use in medical anthropology, might be the ways in which a health system is built up. So, the health system is so crowded and for profit, so or if it's a Medicare or Medicaid system, it's there's not enough money coming in, right? People are just financially strapped. So you have to see 60 patients, right? You have to just run through patients. You have so little time. Patients don't feel cared for.
Yeah.
And we know that's a reality, but structural silencing also brings in this notion that clinicians, not only do they have little time, but they have almost no training in recognizing and understanding complex chronic conditions. So it's not only silencing because of the structural inequality, but it's silencing because of the cultural non-believing of complex chronic conditions and what they look like in women. And that combination, I think, is particularly toxic to this community. And I mean, you can have whatever argument of what it means is causing it, and that is like a whole different question. But the idea of structural silencing is a condition that is experienced across all of these conditions, and that's why invisible illness is a meta think on living with complex chronic conditions and a critique of medicine, because the structural silencing is really harming people.
Absolutely. And I would imagine further contributing to why we don't have these understanding of the biological cascades and causes and, to things like ME and long COVID and all of the conditions that historically get dismissed.
Yeah, it's such a challenge. But at the end of the day, we keep giving corporations more power, and it's just making us so sick. I mean, as a society, it's just really upsetting.
I agree. I'm curious if do you talk about advocacy in the book, ways in which to get involved, or can you talk about them here at all?
I do not really. It's not like a "this is how you do it" book. It's
Sure.
it's really talking about how we got here.
Yeah.
But I also do. I think I talk a lot about the power of embodied health movements. So the power of the HIV movement and how that weaved into breast cancer movements and ME movements and really the power. I think the long COVID activists have been just brilliant and so powerful, because they built on disability justice movements, and they built on racial justice and justice movements, and just really powerful organized leaders, and they've been able to learn from and build on this leadership. And it's been, I think, really remarkable to see them kind of grab power and transform in really meaningful ways. And I think that's been really important. And so I do talk about those social movements and how we understand them and how long COVID needs to be really recognized as a disability issue.
Yeah.
But yeah, it's not really a how-to book, but I think you can read
Yeah.
it and see how you can become really active and what it means to advocate for yourself as well for others.
Yeah, because I mean, in order to go into advocacy work, you really have to, again, unfortunately, this is more of a class divide, but in order to be taken seriously when you're advocating, you have to be educated. You have to be able to speak well. You have to be able to back up what you're saying. And I mean, I'm all for education and being able to back up what you're saying, but it does create a further barricade for people who are not able to.
Yeah. I mean, I've given notes to the national academies on the urgency of long COVID. I mean, I've several times I've reported and engaged at this level. And so I've done advocacy, but I think it's really, really hard to get involved. And especially with the dwindling money. I mean, people have with the Trump administration, there's more cost on families, and people have even less money to donate. And, we're all trying to scramble to get money from philanthropic. I mean, I'm in in academia, I'm in public health, two primary areas that are being absolutely stifled by the administration and delegitimated, which is a huge risk for Americans. So it's just
Absolutely
kind of upsetting.
Yeah, it's very upsetting.
Tough time.
It is. Yeah, I'm right there with you. And I it's unfortunate that everything is unfortunate right now in this administration, but I am really hopeful from a lot of the research that's been coming out, especially like I said, out of the UK. I don't know why all of a sudden it feels like that I think they're doing a lot over there with ME.
Oh,
Um,
I think they always have, and there's been a long history. And actually, what I was talking about, the movement that was kind of interacting with me about the book, a lot of them are from the UK. And I think part of it is because the PACE trial happened in the UK and that there is so much contention around that. And some of the very, very active scholars there are there. So the patient advocacy groups have really powered up there and they're very vocal. And it's important. Their work and their advocacy is incredibly important. And I think they have really amped up with long COVID
yeah.
in an important way. Yeah.
Yeah. And aside from that, the other thing that I'm just trying to constantly focus on is my local politics, just for anyone who's
Absolutely.
listening. We have someone here in Georgia running for governor, who's really trying to expand Medicaid, which has historically been has not been expanded here. They always vote to not expand it in Georgia. So a lot of insurance companies, even private insurance companies, pull out when that happens. People don't realize it affects the entire system.
Yeah.
So little things like that can go a long way, but it really does take a concerted effort. And I think with the globalization, that while there's so much that we learn from each other, I think it really weakens our local systems. And then we don't know how to fight as a team in our systems. So I'm kind of hoping that we're getting back to some of that.
Yeah, absolutely. My local politics I feel very confident in. I'm from Iowa, which is a critical battleground area.
Yeah.
And I actually it's really swung so red, but I think that things are changing and I think people feel really completely ignored or have lied to by the administration. I think things aren't going the way they thought. And I'm very I think it's very interesting to see this, especially with the Maha moms turning on Trump. Fascinating to me. And I absolutely see this. And there's a lot of I really love the have you followed the Red Wine and Blue like mom club? You should look it up. It's actually very interesting, and I haven't like really engaged with it on a personal level, but I've watched it because now that we both know that we're moms and we're like managing our children, in the background at all times.
Yes.
Really having these conversations among women across racial and ethnic groups, across classes, but really centering your power among women to talk. This is where I think advocacy among women and people living with complex chronic illnesses can be so powerful, is just getting your mom groups to really talk about what's happening.
Yeah.
Because women change the world. And when we get power, we change the narrative.
Yes.
And, I actually started so my advocacy is largely through writing. And so that's why giving like normal, like what everyone's so different. Like what's normal for you is not normal for me. And what's normal for my neighbor isn't normal for their neighbor. But for me, my power has always been in communication and writing about things. So I started a new publication called Science Politics because I was just so upset about all of these issues not being talked about. And so I'm editor-in-chief. I launched it with there's 4 of us, 3 other feminist women who really care about talking truth to power and talking about science in a really clear way. Science is political. It is always political. And we can have the best scientific research, but if it's not communicated with the public, no one cares.
Exactly.
And no one understands it. And this administration, did not mean to get this political, but let me tell you, this administration is weaponizing what we know. And they are using, I was actually just revising this piece today that I was reading that is basically about, the Heritage Foundation and others funding these like private consultant researchers to go steal NIH money or data, using their own money to steal and get access to NIH data and basically twist it and publish all of these like really fake studies.
Yes.
So many fake studies. Yeah. And then the administration is using this to oppress people who are non-binary, to oppress people of color, to like create all these eugenic stories that are harmful. They are harming our society and our cultural fabric. And it
Yes.
is really demoralizing. And so recognizing what is real, and what we're doing. I mean, I wrote this book to bring out of the shadows the fact that when you are in a clinical interaction and you are caring for someone who is saying, this is my reality, you need to listen, right?
Yes.
That the patient has deep knowledge. And white women, educated white women are feeling, and Black women who are doctors have told me again and again, I feel like I'm oppressed for my status
Yeah.
in clinical interaction. So it's not just about being impoverished or not having that. I mean, that is a very different experience, but across the board, women are being dismissed. And it is, I mean, and I also feel like misogyny is rearing its ugly head in deep ways. And I think that we can fight against it in the clinical space by education. And it
Would
has to
you
start. It
lump
has to start there.
men into that group who, but when they present with a more effeminate energy or presentation, that they also get treated the same way? Or would you say that you haven't found that in your, or do
So,
you
like,
only?
I mean, I think
Yeah.
we know from HIV that men who identify as gay, for example, or
Even
or
if they're
trans
straight, but
women,
they just are like softer spoken, or they're smaller
right?
framed, or they're, kinder.
I mean,
God
I think it
forbid.
depends. I mean, I think it depends on who is your doctor. I think that I mean, I don't have the data on this, but what I've heard again and again and again and again, and it's definitely not all women. I've met lots of women who are not like this, but often it is a woman clinician who is going to listen to you. And I think that's definitely not the only case. Like, I have lots of family members who are family docs who are incredible, and really open. Actually, my cousin is a family doc, and he bought a stack of my book. And when patients ask him or like bring this up, he's like, "Can I just give you a book that my cousin wrote?" And I made him read it because I was really wanted clinicians to read it and not shut down. Because when you interview patients, if you write a book for patients only, doctors will not take it seriously and they will not read it. And so what I was trying to do is really write a balanced book, because what has to happen is clinicians have to read it if you want anything to change.
Yeah.
And I think just by understanding the nuance of complex chronic illness or living with multiple conditions and what that means, it takes some humility.
Absolutely. 100%. Anything else you want to leave listeners with today? This has been such a great conversation so far. And yeah.
No, we just, I didn't mean to get on this. Like, I
No,
think it's really hard to avoid politics at this
exactly.
moment.
Yeah, we don't get away from that here. I don't have full episodes on it because honestly, I don't have the language for it. I don't have the language for it, but it's always a part of the fabric of every conversation that we have, because it impacts every part of our life. So this is really important.
And it's so important you're doing this work, because I think the most important thing is being able to recognize, as like, all Americans can read a study. And this is why with my students who study global politics, I have them take a scientific article and read it and interpret it. What does this article do? How do you know it's real? Like, what is the analysis? And that is a type of literacy we don't have broadly. So we need to be able to have trusted sources where we can communicate science to a broad audience. It's just so critical. So the work you're doing is just, thank you for including me in it. It's been really nice to meet you.
Here. Absolutely.
Thanks for listening. If you learned something new today, consider writing it down in your phone notes or journal and make that new neural pathway light up. Better yet, I'd love to hear from you. Send me a DM on Instagram, email me, or leave a voice memo for us to play on the next show. The way you summarize your takeaways can be the perfect little soundbite that someone else might need. And lastly, leaving a review really helps others find this podcast, so please do if you found this episode helpful. And P.S., clicking subscribe ensures you'll be here for the next episode. See you then!